These lectures are not designed for use as medical references to diagnose, treat, or prevent medical or mental health illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or mental illness, you should consult your personal physician or other mental health professional.
Allison came to know pain at a very young age. At first, nobody believed her, including her doctors, but her joints hurt, like really hurt, and during a flare-up it was really hard to get around. From the outside, she was an attractive, well-dressed woman that looked totally healthy. In fact, she'd get dirty looks when she parked in a disabled parking spot, despite having a parking permit. Eventually, she was diagnosed with a rare genetic disorder, a sort of autoimmune disease that attacked her joints. But for others, it might be a slipped disc, a broken bone that never quite healed, or recurring kidney stones. Whatever the cause, these patients suffer, and the pain, although familiar, can take on a life of its own. It becomes a chronic pain syndrome. Today, we're going to talk about chronic pain. Not so much about the sensation or the neuroscience, both of which are covered in our mind-body course, but we'll focus on how we can use our CBT toolbox to improve assessment, diversify and improve our pain treatment portfolio, and to manage the psychological suffering that usually accompanies chronic pain. Remember that our CBT toolbox targets both emotion regulation and improved social, occupational, and physical functioning. All will be important as we think about enhancing our quality of life, even in the face of chronic pain. Now, CBT is not meant to be a substitute for other pain interventions, but I think you'll find that it makes a nice addition to your pain treatment protocol. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Just like anxiety or depression, pain, in the right amount and at the right time, can be a valuable source of information. We need to be alerted if we're damaging our bodies. But there are times when it misinforms us, like when we feel pain even when an injury has ended and a wound has healed, or when we feel physical pain resulting from a psychological injury, such as a trauma or a social rejection. Or sometimes the location of the pain doesn't match the location of the injury, like with referred pain. It's important to first distinguish between short-term acute pain and chronic pain. Chronic pain has usually been defined arbitrarily as pain that persists for 3 to 6 months or longer, or beyond the period of expected healing. Ongoing or progressive tissue damage may be present in some types of chronic pain, including progressive neuropathic pain and rheumatologic conditions. In other cases, chronic pain may be present when tissue damage is stable or even undetectable. Unlike acute pain, chronic pain is now thought to be a disease of the central nervous system that involves some sort of maladaptive reprogramming of the brain and/or the spinal cord. The brain can generate terrible pain in a wound that is long healed, or even chronic pain in a limb that no longer exists. On average, 15 to 20% of Americans experience chronic pain each year, close to 50 million people. Headache is the most common, followed by back pain, mostly lower back pain, arthritis pain, and other musculoskeletal pain. Clinically, we think of chronic pain as a syndrome, really as an entirely different disorder. In a way, it takes on a life of its own. We mentioned the reprogramming of the brain and the spinal cord, but that's not all that happens. It also has potentially devastating consequences on mood, depression, anger, social relationships, finances, and of course our self-image. You can think of chronic pain as a chronically stressful condition that essentially keeps the stress response turned on nearly all the time. Sounds like a perfect time to break out our CBT toolbox. Let's watch a quick clip of David, our 73-year-old father and grandfather who's had a recurrence of colon cancer. Although he also has the usual aches and pains of getting older, the main driver of his chronic pain is from his cancer. Without a doubt, he needs medical treatment for his pain, but he shouldn't stop there. As you'll hear, the pain serves as a trigger for cognitions that can make things a lot worse or could make them better. Let's hear it from David. So let's say that you get up to leave today, you walk outside, and you feel a pain in your abdomen. There's likely going to be a thought, right, that pops into mind. And what do you imagine, and we're just pretending here, but what do you imagine that thought might be?
That's triggered by the pain. I mean, immediately my mortality is you know, it's right in front of me, because I can sort of forget about it sometimes, you know, even the time I have left, but the pain is the constant reminder that exists. That, you know, because I think, you know, you go through life, every time you get a pain, you think, what is that? Why is that there? And in my case, I know why it's there.
Right.
And it just says, you know, you will be dying at, you know, sooner than...
Right. So let's think about what the pain is saying, and if there's a way to rewrite that story. So in this case, you're right. We think we know the cause of the pain. It could be indigestion. It could be muscle spasm, right? It could be other things. But we do know that there is a chronic and progressive cause of abdominal pain for you. Won't always be that, but oftentimes it will be. But what that pain means or how you interpret it, that's cognition, right? So it can be interpreted as, uh-oh, it's progressing, it's getting worse, one more day is gone. Or it could be, maybe I need to talk with my pain doctor, or maybe I can go see PT again, or maybe that acupuncture really was helping and I shouldn't have stopped it, or whatever it might be. There's a way to encapsulate the thought to try to prevent it from snowballing and getting bigger, while not denying that it's happened and it has a meaning, but trying to keep it, I guess, in its box and not letting it grow bigger.
That makes sense.
And if that's the case, you know, it hopefully prevents that anxiety from spiraling, but at the same time, you're not just in denial and pretending it's not there.
Right.
So that's the sort of skill we want to help you with. And what we will do is we'll do something called a thought record, and I'll just show you basically what that looks like. There are a couple of key points to this clip that I'd like to review. First, I want to emphasize that using CBT to cope with pain doesn't in any way detract from the realness of the pain. We aren't telling David that the pain is all in his head, that it's just psychological. What we are telling him is that there are ways to use his CBT tools to help him to cope. Secondly, it helps us to think of the pain as the trigger, really just the starting point. That trigger is by definition unpleasant. It's painful. However, we can either grow it or we can shrink it, the experience of pain, depending on what we do next. Recall our lecture on emotion regulation and the modal model of emotion. We talked about something called situational modification and attentional deployment. With situational modification, we might be able to come up with ways to help him preemptively manage his environment so that it's easier to cope. For instance, he might always keep a cane or walking support with him or in his car. He might also plan to limit his activities to those that require less energy or less focus. He needs to know his limits, but it's important for him to still get out and stay active in order to manage his moods. For attentional deployment, it is really about finding effective, high-bandwidth distractions that will take his mind off the pain. For David, who's a musician and a songwriter, music is his best distractor. He can get lost for hours, even when he feels bad. In the clip we just heard, he's using a different CBT tool, a thought record. Now, we made this choice because he started talking about the thoughts that the pain triggers. This is a perfect example of something pain psychologists call pain-related cognitions. These can include beliefs about what the pain is, what it means, what causes it, how bad it might get, and of course your ability to cope. We're particularly interested in how his habits of mind, catastrophizing, magnification, and fortune-telling might come into play. Catastrophizing automatic thoughts would include something like, I can't stand this another second. This is hell and this is ruining my life. There will never be an end to my suffering. While these thoughts are completely understandable, they're not helpful. For David, we took out the 7-column thought record. The sensation of pain was in the first column on the left. This was the trigger. The emotions were in the second column, and they included anxiety, agitation, and hopelessness, and all of them were rated above an 80 intensity. His thoughts in the third column were, oh my God, it's getting worse. This pain means that the clock is ticking faster. It's all going to get worse from here. I'm not sure if I can take this. Now, I'd like to pause and have you think about what David should do next. You have his trigger, pain in his abdomen. You have his emotions. You have his thoughts. There is no doubt that he's suffering, and he needs to think about the pain in a more helpful and constructive way, if possible. How would you help him get to a more balanced and constructive thought? Recall our techniques, looking at evidence for and against. Decentering by having him imagine that he's giving advice to a friend or a loved one. Naming the habits of mind and using linguistic strategies like yes, but, and softening absolute words. We opted to use some linguistic strategies, namely yes, but. Then we started working to reframe the meaning of the pain and to think more constructively. In the end, we ended up with these new thoughts. Yes, my cancer is incurable, and it does sometimes cause me pain. But I have a top-notch oncologist and pain management team that are on call 24/7. I'm not alone in this. And, yes, it's scary as hell, but I don't know how bad this is going to get. But I beat this once before, and I'm still doing pretty well. I can't predict the future. And one last one. This pain may be cancer-related, or it may be something else. It is most likely a benign signal telling me I need to slow down. The message isn't death and suffering, not yet. It's telling me to take a break. I can do that. After his thought record, which cut his negative emotional intensity by half, David decided to do some activity scheduling. Remember that with a chronic disease, it's often hard to make plans and stick with them, but that doesn't mean you can't plan. It just means you need a plan B and maybe a plan C. We'll return to David in our end-of-life lecture to see exactly how he keeps moving ahead to maximize his quality of life, even in the face of knowing he has a progressive illness and limited time left. As I mentioned earlier, CBT will be just one treatment for your chronic pain. You may still need medical treatment such as medications. You may need behavioral interventions like physical therapy or an assistive walking device. You might also work in integrative medicine treatments like yoga, Tai Chi, or mindfulness meditation, or acupuncture. All told, with the help of your medical team, you should put together a pain treatment package, one for everyday pain management, and also one for those really bad days where nothing seems to be working. As with any issue you might want to be working on, you want to first start with assessment, your pain baseline, then plan to reassess as you move forward. Is it working? Is it not working? Remember that you always want data to let you know if your interventions are doing what they're supposed to be doing. After your assessments, you should break out your foundational skill self-monitoring. The assessment surveys will be helpful, but you'll also want day-to-day data on your pain levels, what helps, what hurt, what things have you tried, what things haven't you tried just yet. So let's pause there and let you think about how you'll find initial assessment tools. Now, in the past, I've given a few sample survey items and maybe a URL for a survey. What we've learned over our various courses is that those URLs change often. So rather than give you a fish, I want you to be able to go fishing on your own and find these surveys. So you'll go to Google or whichever search engine you prefer, and you'll enter what terms? Remember, more specific is better. If you're at home and you have internet access, try doing the search now and seeing what PDF surveys that you can find. Now, when I did this, I entered the terms chronic pain, assessment, and public domain because we really want readily available questionnaires. The three with the most hits were the McGill Pain Questionnaire, the PEG, P-E-G, and the Brief Pain Inventory. Now, 2 of the 3 had PDFs after some poking around. One trick you can try is to switch to an image-only search by clicking Images under the search bar. This gives you all the saved screenshots of questionnaires folks have uploaded. So even if the PDF isn't there or it's behind a paywall, odds are that someone has taken a photo and posted it online, and you can then print it out. In our primary care practice, we need something brief, so we used the 3-item PEG. P is for pain intensity, E for how much pain affects your enjoyment of life, and G for how much pain affects your general activities. All of the items scored on a 1 to 10 scale are: question 1, this is the P, what number best describes your pain on average in the past week? So simple 1 to 10 scale. Question 2, what number best describes how during the past week pain has interfered with your enjoyment of life? 1, not at all, 10, completely. 3, what number best describes how during the past week pain has interfered with your general activity? Now notice that each of these have a time course of 1 week, meaning that the PEG was meant to be re-administered on a weekly basis. You can use it as an initial assessment, but you probably also want to use it as a weekly assessment or a form of self-monitoring. You might also have noticed in your search that something called the VAS popped up. Now, VAS just stands for Visual Analog Scale, and it's a simple scale from usually 1 to 100 where you rate the intensity of your pain, or really you could use a VAS for just about anything. Now, a visual analog scale is great because you can essentially create your own quantitative, simple assessment item. Okay, so you have your initial pain assessment that you'll repeat at least every week or 2. Next, you need some sort of self-monitoring form. Again, there's no need to reinvent the wheel. Go back to Google and search. What terms would you use? I typed in CBT pain diary, then clicked on the images button. You'll see lots of partial pain diaries, but they want you to sign up, or they want your personal information, or they want you to pay. That's no good. I went back to the general search and found a PDF for My Pain Diary put out by the nonprofit in Australia. But it's not bad, and it's free. The column headings are, starting at the left, date and time. The next column, you describe your pain. You rate the pain intensity, what helped, what made it worse. You describe your activity that you were doing at the time. You rate your mood, and then you have a column for general comments. What I like here is it's tapping into both the biological, psychological, behavioral, and social elements. I would recommend either using this one or just creating your own. I would make sure you write in what you tried to better manage your pain and whether or not it worked. Remember that this is a frontline, real-world data that tells you what helps and what doesn't. It's messy, but it's useful. Okay, so we have our assessment and our self-monitoring, both CBT tools. Now we should think about our broader package of interventions where CBT is just one of potentially many. Let's go back to the case of Scott. Now, he's the middle-aged man with a pinched nerve in his back that was overprescribed opioids. He was first introduced in our addiction lecture because the treatment he was given for his pain, opioids, was unimodal and became its own problem. Here we see Scott thinking about his pain management package and what else it could entail.
I tried doing exercises for a while, but I think maybe I had the wrong ones. Do you think exercise could make me not need the pills as much?
So if you look at the research on having a pinched nerve, so having degenerative disc disease where the vertebrae push down on top of a nerve, the best way to treat that is through strengthening your core. And there's a number of physical therapy exercises that you can use. It's best to go for probably, it's usually 6 to 10 visits or so, where they will do the exercises with you. It's kind of like having a personal trainer, but then it's something that you need to do several times a week, if not every day. If you look at the research, that's the #1 sort of most effective strategy to treat your pain. The side effects of that is you get in better shape, right? You have better posture. You probably will lose a little bit of weight. Some people even see things like slight reduction in blood pressure as they become more physically active and healthier. So physical therapy, absolutely. And then the other part of the package will be cognitive behavioral therapy. And as I mentioned, we'll be addressing those pain-related cognitions, and we'll also be thinking about strategies to both turn down the heat in terms of stress, anxiety, depression, but to also think about ways to help you stick with physical therapy, to help you be more active, both for treating your back pain, but also just for treating your mood. Okay, great. So Scott's package is still going to include medications, some opioids, but at a lower dose, and some medications for neuropathic pain. However, he's also going to include physical therapy, exercise, and cognitive behavioral therapy, particularly for stress management and emotion regulation. We also know that he will use CBT to help him limit his opioid use, to cope with cravings, and to address his cognitions around pain and opioids. Now, I guessed one of his challenges might be unrealistic expectations, so I asked him about his pain management goals. Let's take a look. So Scott, why don't we transition to talk a little bit about goals? And I know we have the broad goal of tapering down opioids, treating your opioid use disorder, and helping you to more effectively manage your pain. But let's take a closer look at pain. So what would be a goal for you in terms of pain management? Where would you like us to get to?
Well, guess I'd just like to feel numb.
Okay, all right. Say more about that.
Well, I mean, isn't numbness the absence of pain? That's the best way to describe getting rid of all the pain I've got now. It's just numb would be good.
Okay. And what do you imagine numb would do to relationships or work or your mood or life or...
It's just kind of hard to think about all that right now, you know. The pain's still there, you know, we kind of covered that. So, you know, when you're at the dentist, they numb you up, and I kind of would like that for my back.
Right. And I hear you, and it's absolutely understandable, and we would all like to be pain-free, right? That's absolutely the place where I think we would all want to go. There's a difference, though, between acute pain, like going to the dentist where they're doing a procedure and it ends and the pain goes away, versus chronic pain from an anatomical problem like degenerative disc disease, that if you were to be numb all the time, I would worry if you were able to connect with your family, if you were able to function at your job, if you're able to do the things that cause you to feel successful at work. So let's say that our goal is to reduce pain as much as possible. And 0 would be sort of the star on the horizon, but realizing, you know, we usually don't get to the star, but we get as close, you know, as we possibly can. It's the direction that we want to head towards. What are some of your goals in terms of functionality? So if we wanted to give you your life back, what would that look like? What would be different?
Well, I'm going to turn 50 next year, but I've got some friends that still play basketball. I haven't thought about doing anything like that in years, but they can be 50 and still do that. I would like to do that. You know, I would like to go on hikes with my kids. One of my kids is into hiking. And there's all sorts of things I'd like to do. I'd like to be more than just able to keep my job. I'd like to think I've got another 15 years of doing something, you know, more than just staying employed. Yeah. So these are all things I'd love to do. It just hasn't been possible for 2 years.
Yeah. So I want us to go in that direction. And as we think about goals, as we think about positive outcome for coming to therapy or from doing this sort of pain management package that we've talked about, it's getting your life back. It's reconnecting with who you used to be. It's, you know, going on hikes. It's doing sports. It's being productive, successful, getting promoted at work. And you're right, life is not over at 50 for sure. So there's lots and lots that you can still do and lots to look forward to. Now, it's likely, given the diagnosis that you have, that there will be periods of pain that come and go. We want to minimize how frequently those occur, and we want to minimize how intense the pain is. But I think we'll want to realistically approach, you know, the future is going to mean there's probably going to be a lot of PT for you, physical therapy for you. There'll probably be some medications for neuropathic pain. Back pain is the absolute most common form of pain that people have. Nearly everyone has some form of low back pain at some period of time. It's learning how to live with it and learning how to still be as functional as you possibly can given the pain that you have. So here we see a common and mostly unhelpful goal of being numb. It's understandable, but it isn't helpful. A better goal relates to quality of life, to functionality. Being numb doesn't help us with that. So if you're thinking of goals for yourself or a loved one, think of functionality. What is it you'd like to get back? Going for walks? Holding your little one? Being able to sit and read without discomfort? Get concrete and specific, then measure your baseline so you can see your starting point. Let's listen to just one more clip of Scott as his pain-related and age-related cognitions start to emerge. Here we are squarely back in CBT territory.
Well, see, here's the thing. When I say I want to be numb, right? I know that there's life after 50, but, you only get worse as you age. So if I can't deal with this now, how am I going to be able to deal with this in 20 years if things just get worse over time? That's why I'm not really thinking about, these higher goals, because I think, well, what's the alternative to it just getting gradually worse every year?
So I'm writing down that thought, and we mentioned there are pain-related cognitions. I think there are cognitions related to chronic diseases too that can cause us to feel discouraged or to even feel hopeless. So you only get worse as you age is the thought that you wrote down. And I would say that is an opinion, and opinions are things that we test out. So we'll want to look for evidence for and against. We will want to look for more helpful, constructive ways to think about aging. You're right, our bodies do change. That's just a physiologic fact. But it doesn't mean that you're going to continue to progressively lose discs in your back, that you're going to go from a pinched nerve to 2 to 3 to 4 to 5 to complete immobility. In fact, the course of the disease doesn't tend to go that way. But I want us to bookmark that, so then we're doing thought record exercises. I'll have you come up with evidence for and against. I'll have you come up with potential counter-cognitions that might help you feel a little less hopeless.
All right. I'm willing to listen to that.
So now we're back to a thought record, a core CBT tool. Think about the other tools in your toolbox. What else might help Scott? You might try graded task assignment, behavioral activation, somatic quieting, cognitive coping statements. You might try thought records or even attentional deployment. Really any tool that he might feel comfortable with. In the end, you'll want to come up with a coping plan and a panic plan. Panic in the sense of what to do during a serious pain flare-up other than panic. But first, let's talk about the coping plan, or really a compilation of strategies that you might find helpful. Here's a sample plan taken from a real patient named Beth Thorpe, a 59-year-old woman that has struggled with chronic pain for 18 years. Her plan included, first, emphasize movement and exercise. Even if in pain, it's always important to move. 2, change of scenery. Even though I might feel like I'm in a lot of pain and I don't want to go anywhere, sometimes getting out of the house is just the distraction or the enjoyment that I need. 3rd, distraction. Whether I'm at home or whether I'm out, taking my mind elsewhere. And of course, we would call that attentional deployment. 4, using support groups, either in person or online support groups, can be really helpful, talking to people who understand where you're coming from. And 5 is to know your limits and don't overdo. It's important to stay active, but also to know how active is the right amount. For your panic plan, you'll need to consult your doctor about what you should or shouldn't do in terms of adjusting your medications. She can also give you a better sense of when chronic pain is an emergency that requires an ER visit versus something you can maybe deal with on your own or with your family. Can you take extra pain pills? Maybe. Should you use massage, heat, a TENS unit? Be sure to list out all your strategies and have them handy when you need them. Most of my chronic pain patients print out their pain panic plan and include their doctor's numbers on it so that family members can stay oriented too. For our next lecture, we'll discuss a common phenomenon that can worsen pain or a number of other illnesses. It's quite common and can be quite debilitating. In our next lecture, we'll talk about insomnia and what you can do to get better sleep. Until then, thank you.